Welcome to Advances in the Management of Chronic Gout. I'm Dr. Leonard Calabrese, Professor of Medicine at the Cleveland Clinic Lerner College of Medicine. Today we're going to be discussing gout, a disease that is common, is attended by significant morbidity, but unfortunately one that is often not optimally managed. Our learning objectives today are fourfold. We're going to discuss the role of monosodium urate crystals in the activation, dysregulation of inflammasomes. We'll review the criteria for confirming the diagnosis of gout. We'll also summarize the current guidelines for the management of gout. And finally, we're going to talk about the evaluation of therapeutic targets in a treat-to-target strategy for this disease. To deliver this program, I've assembled an all-star faculty. First, to talk about the basic science aspects this morning is Dr. Robert Terkeltaub, Professor of Medicine at the University of California at San Diego. Next, to talk about some management issues is my friend and colleague, Brian Mandell, who is the chairman of the Department of Medicine in the Education Institute at our institution. And finally, Dr. Peter Lipsky, a frequent visitor and contributor to our CME programs, who will address the treat-to-target strategy. Dr. Lipsky is currently CEO of AMPEL BioSolutions in Charlottesville, Virginia. Our first talk this morning will be on the biology of uric acid. Great advances have been made in this field, and certainly there are few people that could address this better than Dr. Terkeltaub. Thanks for coming to Cleveland.
Thanks, Len. We're going to talk about the biology of uric acid and how the crystallization of uric acid leads to inflammation in this disease. And we'll go over some of the basic science advances that are relevant to translational medicine here. So a common foundation for understanding gout is that we're dealing with a disease where there's excess body uric acid burden, and this is reflected by hyperuricemia. And we know that the definition of hyperuricemia is a physical chemical definition, not a population average definition, and it's traditionally a uric acid that's greater than 6.8 or greater than 7.0 milligrams per deciliter, depending on what the preference is of the investigators. And asymptomatic hyperuricemia is really markedly common in the American population and that in developing countries. We're dealing with over 20% of adults having asymptomatic hyperuricemia. And many of those people, typically at least 20% of those people by a time point of 5 years, will go on to develop gout. And then, of course, the mean serum uric acid in the United States is very close to this saturability threshold. It's close to 5.5. It's risen. And this makes the window between the population mean serum uric acid and hyperuricemia quite narrow. And most importantly, the gout prevalence in the United States adults has risen to close to 4%. We're dealing with essentially an epidemic of gout. It's approximately doubled in prevalence in the United States over the last couple of decades. So, and we're also seeing way more severe cases. And so understanding gout starts with understanding the biology of uric acid production. It used to be thought, on the right-hand side of this figure, you can see the inborn errors of metabolism. It used to be thought that heritable influences on hyperuricemia were a very small proportion of the cases of gout in terms of driving the uric acid levels up. And it used to be thought that it was really rare to see these heritable influences via the uncommon conditions of PRPP synthase superactivity and HPRT deficiency, all on the right-hand side of the slide. And we recognize now that there is a common component driving uric acid increased production of increased sugars in the diet, and this is driven principally by fructose, which is 50% of table sugar, and a higher proportion in high fructose corn syrup, which is enriched in so many of our dietary products, including sweetened sodas. And we recognize, of course, that xanthine oxidase on the bottom of your slide is at the end point of uric acid production by breaking down hypoxanthine to xanthine and then xanthine to uric acid. And of course, hepatic xanthine oxidase remains the dominant force in systemic uric acid production, but xanthine oxidase used to be thought of just being in the liver and in platelets, so we now recognize that it's present in endothelium and can have an increase in expression under conditions of endothelial stress. It's present and expressed in fat cells, in macrophages, and that xanthine oxidase inhibition may have an impressive contribution to therapeutic effects on some comorbidities, including cardiovascular disease, by inhibiting xanthine oxidase pro-inflammatory events at the level of endothelium and macrophages. So there is significant biology of xanthine oxidase and the use of xanthine oxidase inhibitors that is becoming recognized. But really the dominant force in heritable hyperuricemia is going to be the effects of some of these heritable traits on urate handling in not only the kidney, but also the small intestine, which we'll get to shortly in this talk. I think a really fundamental component of understanding uric acid biology is that the enzyme uricase, which is not expressed in human beings, it became a pseudogene in evolution. Uricase drives the degradation of uric acid to a much more soluble compound, allantoin. And so the normal serum uric acid in mice and rats is close to 1 to 2 milligrams per deciliter, whereas the uricase knockout mouse, it becomes approximately 10 milligrams per deciliter, and these animals develop uric acid tubulopathy and renal failure unless they're treated with a xanthine oxidase inhibitor or with uricase. And so this is a fundamental reason why the normal serum uric acid in humans comes in at about 6 milligrams per deciliter. So in terms of the heritability of hyperuricemia, we have to understand how uric acid is disposed of in the renal proximal tubule epithelial cell and also in the small intestine. And so this slide illustrates in the center how the renal proximal tubule epithelial cell reabsorbs urate anion. And the reabsorption dominates over the secretion of urate into the lumen of the proximal tubule epithelial cell. And so the key players are illustrated on the left, first of all. URAT1, which is encoded by the gene SLC22A12. It's crucial for urate anion reabsorption, and it's the drug target of all potent uricosurics, and this includes probenecid and the recently FDA-approved compound lesinurad. And it's modulated in expression by sex hormones, and it's decreased in expression by estrogen, for example. And there's function in activating gene variants that can cause a low serum uric acid level, and they're protective for the risk of developing gout. And URAT1, as you can see in the slide, is an anion exchanger, and it exchanges monocarboxylates, including lactate, butyrate, niacin, nicotinic acid, salicylates, and others for urate, to bring urate back into the proximal tubule epithelial cell, where it can then undergo either secretion or reabsorption that's encoded principally by GLUT9, as you can see on the right-hand side of this slide. GLUT9 is encoded by the gene SLC2A92, is a major factor in heritable hyperuricemia. It's crucial for urate anion reabsorption into the circulation. It's also a sugar transporter. And function in activating gene variants of GLUT9 also cause hereditary hypouricemia, and the presentation of that can include exercise-induced renal failure due to uric acid crystallization in the lumen of the renal collecting system. OAT4 on the left-hand side of the slide is a molecule that's a drug target of lesinurad, and it mediates diuretic-induced hyperuricemia as well as heritable hyperuricemia. And so in terms of the uric acid elimination by the renal proximal tubule epithelial cell, this slide summarizes the major urate anion secretion pathways. So here in the middle, again, is a diagram of the renal proximal tubule epithelial cell, and you can see that there's an array of transporters of urate anion that includes ABCG2 on the upper left-hand side of the slide. And ABCG2 is a very important molecule in heritable hyperuricemia. It is a high-capacity urate anion transporter. It's active not only in the kidney, but also in the small intestine, where it promotes urate secretion into the small intestine. The urate gets into the colon, where bacteria in the colon express uricase and break down uric acid in the colon. And normally the amount of urate that's eliminated by this pathway is somewhere between 200 and 300 milligrams a day, but compromising this important small intestinal pathway of urate anion elimination definitely promotes hyperuricemia in a substantial way, and particularly frequent in Southeast Asian population groups, including Japanese, Pacific Islanders, and Han Chinese. And so the ABCG2 variants, gene variants that are associated with hyperuricemia and gout are actually quite common, and we'll discuss those in a moment. But they include variants that are as common as 30% of the population in many Southeast Asian populations, as well as 10% of whites and 5% of blacks. And the ABCG2 function inactivating gene variant Q141K drives early onset gout mediated by renal uric acid underexcretion. And if there's enough gene dosing of variants of ABCG2 that limit urate anion transport, there's decreased extrarenal excretion of uric acid, and there becomes renal uric acid overload, which you can detect in part by seeing an elevated 24-hour urine uric acid without uric acid overproduction, true uric acid overproduction. And so also the ABCG2 transporter transports allopurinol and its active metabolite oxypurinol, and the Q141K mutant, which is approximately 50% functional, is associated with decreased allopurinol responsiveness. So there's tremendous potential for precision medicine based on understanding these particular transporters. Some of the minor transporters involved in uric acid excretion at the renal proximal tubule epithelial cell level include NPT1. And so the new classification of gout is on the right and the old on the left. And the new classification includes renal uric acid overload due to decreased function of ABCG2, whereas the old classification on the left classified into uric acid overproduction and the major category of uric acid underexcretion by the kidney or combined types. The new genetics of gout susceptibility really involve the understanding of these renal urate anion transporters. This is a Manhattan plot of the major GWAS study, genome-wide association study, showing that ABCG2 on the middle left of the slide and SLC2A9, GLUT9, encoding ABCG2 and GLUT9 have had the most consistent impact on increasing the susceptibility to hyperuricemia and gout across different populations. But there's many other genes involved, including some genes that affect glucose metabolism and the pentose pathway shunting that can also contribute to uric acid overproduction. So genetics and multiple environmental factors contribute to the phenotypic variation of gout that we see, including early onset disease, and the effects of the environmental component are going to be more pronounced in women, as you can see on the right, but clearly heritability plays much more of a role in hyperuricemia and gout than we used to think of. So in addition, in terms of the comorbidities involved in increasing risk of incident gout, we recognize that CKD stage 3 or worse is something that markedly increases the risk of incident gout. As you can see here in this follow-up study, which looked at development of incident gout over 7 years, there's a spectacular rise in incident gout with an estimated GFR of less than 60. So some of the other factors that are proposed to affect the predisposition to developing gout, including in hyperuricemic states, are listed here. We recognize that tophi that form, it's not just a matter of what the serum uric acid is, that there may be other underlying influences, including potentially adaptive immunity, not just innate immunity, as well as connective tissue extracellular matrix composition, for example, seeing tophaceous deposits in osteoarthritic joints. And so the tophus itself is a granuloma, and you can see the centrosome with crystals deposited in this corona that includes not just macrophages and neutrophils, but also B cells, T cells, and plasma cells. And we think probably that some of these adaptive immune responses can help to promote crystal deposition and also quieten down some of the inflammatory responses to urate crystals in the developing tophus, so that the developing tophus can gain in size steadily over years. And so in terms of how you ultimately get the phenotypic expression of gout as inflammation, this is mediated by, in large part, the NLRP3 inflammasome being activated. The monosodium urate crystals, as you can see at the top, comprise the second signal for inducing NLRP3 inflammasome activation. They're ingested by monocyte macrophage lineage cells. They're phagocytosed and disrupt the phag lysosome, leading to the cascade of NLRP3 inflammasome activation, caspase-1 cleavage, IL-1 beta cleavage, maturation, and secretion, and then the promotion of acute inflammation. And we recognize that you need first signals also to prime the inflammasome for the second signal. And these first signals are variable and include dietary fatty acids, complement, and some of the effects of dietary fatty acids and their breakdown products can have opposing effects on the inflammatory potential of urate crystals. And so here's a slide that summarizes the comorbidities of gout in the Nahanis USA survey of 2007 and 8. We can see that we're dealing in gout with not just the sequelae of urate crystal deposition, but also the challenge of managing patients with all of these associated and quite significant medical conditions. And so, and alcohol abuse was not even included in these particular results. So I think that these data shed light on how systemically affected gout patients are in terms of medical illness. And a mountain of evidence links hyperuricemia and gout to these comorbidities, including excess cardiac mortality, hypertension, chronic kidney disease. And it's interesting that there are favorable effects of xanthine oxidase inhibitor treatment on cardiovascular outcomes in association studies, but very few randomized prospective clinical trials. I've put some examples of some of the association studies with favorable effects of xanthine oxidase inhibitor treatment on cardiovascular outcomes. There have been some causative studies in basic science to suggest that xanthine oxidase inhibitor therapy is actually anti-inflammatory and can directly inhibit atherogenesis in vivo. So I'll refer you to Nomura et al. In 2014 in that publication. And we have a new way of thinking about uric acid and xanthine oxidase, though, in gout comorbidities. Uric acid is not simply an inert end product of purine metabolism, but can act as a pro-oxidant and can deplete nitric oxide in the vasculature and promote hypertension. Being widely expressed outside the liver, xanthine oxidase has pro-inflammatory and potentially pro-atherogenic effects. And so the breakdown products of uric acid, some of these oxidative breakdown products are listed on this slide. And all of these are detected in human urine, for example. So uric acid really isn't inert. And we have to think about what some of these breakdown products do in terms of contributing to comorbidity. And so clearly, though, uric acid is known to deplete nitric oxide at the level of the vasculature. This cartoon shows the endothelial cells and uric acid promoting nitric oxide depletion. And this loss of vasodilator effect can be important in terms of modulation of blood pressure as well as other sequelae in the vasculature. So this slide provides a current overview of uric acid metabolism that promotes renal and non-renal diseases, including oxidative stress. Xanthine oxidase itself will generate reactive oxygen species and nitric oxide depletion, and the possible ability of uric acid to promote vascular smooth muscle proliferation. So our conclusions are that altered urate, renal, and gut disposition, not simply uric acid overproduction, play the most dominant roles in heritability of gout. This is a major recent advance. The membrane transporter ABCG2 is a very busy molecule because it modulates not only urate secretion into the renal proximal tubule epithelial cell lumen, but also responsiveness to allopurinol, and it critically modulates urate anion secretion into the small intestine to help lower serum uric acid. The loss of uricase in human evolution has imposed a very narrow window between a normal serum urate and hyperuricemia. And uric acid is not inert. It can act as a pro-oxidant or antioxidant, and this is dependent on the milieu and on oxidative modifications of uric acid that we can actually see occurring in human beings. Uric acid and xanthine oxidase can modulate tissue inflammation and tissue damage, and then innate immunity and as well potentially adaptive immunity can regulate uric acid biology at the tissue level, including in how tophi form and grow. And then we clearly need a much larger number of randomized prospective studies to code the complicated connections between hyperuricemia and xanthine oxidase activity with cardiorenal and metabolic comorbidities that are highly prevalent in gout patients. Thank you.
Thanks, Bob. That was really terrific. So Brian, you're up, and you're going to address the diagnosis and management of chronic gout for us.
Good. Thanks, Lenny.
As Len said in the introduction, gout is incredibly common in almost everyone's practices: rheumatologists, general internists, family medicine, ER docs. And yet there seems to be a lot of problems with the management. And I think part of the issues that arise is the consideration that gout is really only an acute issue of acute flares, when in fact, as I hope to emphasize in this talk, it really is a chronic disease. Gout is really the urate deposition in and around joints. That deposition comes from the urate circulating being above its saturation point, which is about 6.8 milligrams per deciliter. And from years of running levels like that, the joints and the periarticular structures will actually be coated with urate crystals. The clinical features of gout, which gets patients' attention and ED docs' attention, are the episodic acute inflammatory arthritis, the soft tissue lumps and bumps of tophi, the joint symptoms of chronic pain and swelling, which is related to a low level of chronic synovitis, and even chronic bursitis and tendinitis. As Bob has emphasized in his talk, urate deposition also contributes to the development of the metabolic syndrome, and particularly hypertension and chronic kidney disease. If we think about gouty arthritis, the progression of gout in a given patient, there's a period of time that is really essentially asymptomatic, where you have high levels of urate defined as above that 6.8 saturation point. The first attack will happen, it'll be self-limited and resolve, and over time, additional flares will happen. But if the urate isn't controlled and the deposition continues to occur, there will be an increasing frequency of attacks. The time between attacks gets shorter, the attacks tend to be more severe and last longer, until you finally have, in some patients, really a chronic arthritis that develops. This is what's going on at the end in some patients, but it's incredibly important to realize that even back at the point where the patient is asymptomatic, deposition is going on. It can be seen with dual energy CT, as you see with the color picture there, or even by ultrasound. You can demonstrate that the deposition is happening even when patients are asymptomatic. So gout is not just the episodes of the acute red swollen joint. It really is a chronic deposition of urate in areas that we really don't want it to be, which under sophisticated imaging we can detect, but it tends to be clinically silent. And I think this has really created the management issue with most of our patients with gout. And it doesn't need to be that way, and conceptually I think we should think about this more as we think about vascular disease. And if we treated gout as we treated coronary artery disease, we would treat this a little bit differently. Picture the patient who has coronary disease in an MI or an acute coronary syndrome. You could either do symptomatic treatment or disease management. In symptomatic treatment, you do some intervention. The MI hopefully is prevented or limited in terms of its infarct size. If you don't give any additional treatment, what happens is atherosclerosis obviously progresses, the lumen narrows further, and you'll have a recurrence of coronary syndromes. On the other hand, which is what is well accepted practice, you treat the acute event, you resolve that, you go on to statin or other cholesterol lowering therapy, and the goal is that you're going to prevent MI by preventing atherosclerotic progression. And that really, hopefully, is a therapeutic cure. If you use that metaphor and think about the management of patients with hyperuricemia and gout, you could do symptomatic treatment for the acute attack with any one of a number of drugs. But if you don't introduce urate lowering therapy, what's going to happen is the deposition is continue to occur and there are going to be recurrent attacks. On the other hand, if you really do the model of limiting atherosclerotic plaque and translate that to limiting urate deposition with disease management, you introduce some form of therapy, of urate lowering therapy. Ultimately, those crystals will dissolve, they will go away, the deposition stops, and you will have actually a therapeutic remission. And just like as we manage patients with coronary disease, just because someone doesn't have an acute gout attack doesn't mean we should stop urate lowering therapy. We want to prevent the recurrence of reaccumulation of urate. So we can't ignore the acute gout flares, and the goals are to stop those attacks as quickly as possible. Our choice of drugs, of which we actually have several, is generally determined by the comorbidities of the individual patient. We want to prevent recurrent attacks by limiting inflammation with maintenance, low-dose colchicine. Sometimes we'll use low-dose NSAIDs. Patient education is really the key, but the long-term maintenance and actual goal of therapeutic remission here is really to reverse the complications resulting from chronic hyperuricemia and urate deposition by using urate lowering therapy. There's no other way that ultimately we're going to prevent these attacks from happening. Now we do have different options. We have two xanthine oxidase inhibitors, both of which reduce the production of uric acid. Allopurinol we've had for decades. The rule of using this drug is generally we start at a low dose. It comes in 100 milligram pills. You should start with 100 milligrams or even half a pill. Particularly in those who have chronic kidney disease, you want to start at a low dose. You wanted to start at a low dose so first of all because you want to lower the urate slowly. This makes having a mobilization attack or an acute attack less likely to happen as we start to get rid of the urate deposition. But also in the setting of chronic kidney disease, this seems to make it even less likely to have it as hypersensitivity reaction to urate. But most importantly, you then need to titrate the dose of allopurinol up. And this can be done every 2 to 5 weeks to whatever the physician is comfortable with in raising the dose of allopurinol. The goal is that you need to get that urate significantly below 6.8. 6.0 is a very reasonable target. The reason is that we want to keep it below the saturation point and we're actually dissolving the positive urate as opposed to letting them continue. What's the maximum dose? The FDA says 800, in Europe it's 900. The fact is we don't know that higher doses are necessarily bad for anyone. It's just that we don't have the safety data in control ways to know that. Febuxostat is an alternative xanthine oxidase inhibitor. It's extremely effective. It just happens to be, at least in the States, far more expensive. Same principles here. Start at a low dose. 40 milligrams is the pill. I like to have started even at 20, which is off-label use because it involves cutting the pill. About 40 milligrams is roughly in the clinical trials similar to allopurinol 300 milligrams, but you can certainly increase this just as we increase allopurinol to at least 80 milligrams once a day. There's uric acidic therapies. A long time we've had probenecid. This can be used as monotherapy. It's a little bit more difficult to use than the xanthine oxidase inhibitors. It's effective really only in folks who have reasonable renal function. Fenofibrate or losartan are reasonable adjunctive therapies, probably not sufficient in most patients to get to that target of 6. If you have a history of urolithiasis or very high renal excretion of uric acid, we generally try to avoid uric acidic therapies. The new kid on the block, lesinurad, was recently approved. It's extremely effective. We don't know the pricing yet, but very important for this drug is that it is not monotherapy. It's really of use as combination therapy with a xanthine oxidase inhibitor. So we look a little bit more closely at the xanthine oxidase inhibitors, particularly looking at allopurinol. There's a large number of patients, as you look at population studies, who fail to achieve a target serum urate of 6 or below. Now, if you use 300 milligrams as your target, only about a third of patients or less will get to this target. But as I emphasize, 300 milligrams is not the dose of allopurinol. The dose is whatever dose you need to get. And the problem is we look at populations of patients being treated with allopurinol, non-adherence, and that I think falls on us as physicians generally because of a lack of education and engagement of our patients with really the approach to get rid of those urate deposits. We're also at blame if we underdose. If we don't check the urate again, if we don't increase the dose of allopurinol, we're not going to be able to get to that target. And then there are some patients who actually will have resistance to allopurinol, increasing the dose to 900 milligrams, 1,000, or even above in some patients. We still can't get to the target level of 6 or below. This is the minority of patients, but they are a very real population. And in those patients, we need to either switch from allopurinol to a different drug, febuxostat, or use a drug with an alternative mechanism, or even add a uric acidic. So lesinurad, as I mentioned, is the newer uric acidic. Here are some data from the clinical trials of use in combination with allopurinol. And you can see with placebo plus allopurinol 300, only about 30% of patients got to that urate less than 6. But if you combine it with 200 milligrams, you get to 60+%. And if you were to increase the dose of the xanthine oxidase inhibitor, either febuxostat or allopurinol, that number will go significantly higher than 60%. So the idea of a combination of a uric acidic drug, such as lesinurad, plus allopurinol, febuxostat, an extremely effective way to lower the serum urate. But again, to emphasize, lesinurad is not a monotherapy drug. The reason is that there was an increased chance of acute, although reversible, renal injury if you used it as monotherapy. So there is a black box warning about acute renal failure occurring with the use of this drug, and thus it should be used with a xanthine oxidase inhibitor. The major events that were noted in clinical trials were reversible, a rise in serum creatinine, thus this needs to be monitored. So the basic principle of urate lowering therapy, why we do it, how we do it, what our target is the idea that the lower the serum urate, the more rapidly a tophus is going to be resorbed, and that includes the intra-articular or periarticular coating of the joints with these urate deposits. Here's an older study from Spain. It looked at 60+ patients who had tophaceous gout who were followed for 5 years. They had had gout for a long time. They were treated with allopurinol or benzbromarone, a uric acidic, or the combination of both. And they just followed and looked at the rate of tophus reduction. And as you can see here, clearly the lower the serum urate, the more rapid the reduction in tophus size. But the key variable here is the passage of time. So even if you lower the urate to 5, 6, or even 4, it's going to take a very long time to dissolve tophi, particularly a visible tophi at the end of an elbow that may be the size of a golf ball. So what happens if we drive the urate dramatically lower to less than 1? which we can do with some therapies. So the traditional therapies I talked about with the xanthine oxidase inhibitors, the uric acidics, we can get the level down to 5, 4, sometimes even in 3, but not so easily. The new kid, if you will, over the past decade is pegloticase, which is replacing the uricase, which as Bob Terkeltaub mentioned in his talk, we as humans don't have an active uricase. So if you basically do enzyme replacement therapy with pegloticase, we can drop the serum urate dramatically, and in responders, which unfortunately is only about 40%, but in those responders, we can drop the level of serum urate down to unmeasurable, less than 0.5, often less than 0.2. And here graphically, work from Herb Baraf from clinical trials show just over the course on the top there of 13 weeks of therapy, you see dramatic visible resolution of the DIP tophus and PIP tophus as well. And you can see in the bottom after 25 weeks of therapy, huge digital intradermal deposits of urate essentially melting away. And again, this is 13 and 25 weeks. The urate level here was basically unmeasurable. The lower the urate, the faster the resorption. Here are some clinical trial data from patients who were given pegloticase infusions. And you see two things here. What plotted is the mean plasma urate level. And the bottom in green, you can see in patients who responded to pegloticase, which means they didn't make any neutralizing antibodies to the drug of significance, you can see that the level, even over the course of 25 weeks, and much longer, in fact, in the open label extension studies, stayed to less than 1 milligram per deciliter. The gray at the top is the placebo group, and as expected, really did not drop at all over the course of this time. The intermediate bar there shows that some patients will respond initially to pegloticase replacement, but then they make neutralizing antibodies and the urate starts to creep up. The nice part about this is actually this is a marker of the drug response. If the urate level isn't very low, it says the patient is making neutralizing antibodies, they're not responding, and in fact, they're the ones that it may be at risk for infusion reactions to this drug. There is some long-term safety on giving pegloticase. There was an open label extension. There's now a lot of clinical experience here. And again, to emphasize that the risk of infusion reactions really can be determined by the loss of activity of the drug and the rise in the serum urate. So patients who are not dropping their level to significantly low levels and certainly not dropping it below 6, well, we should stop the drug because they're not going to respond to this. So in summary, gout is a disease of pathologic deposition of urate. It's not just the acute red hot swollen joints. That if we do deplete the patient of these extra deposits of urate, flares of gouty arthritis will stop once the deposition is removed. The urate deposition can occur by maintaining the serum urate below a target of 6, but the lower the serum urate, the faster the deposits dissolve. So you really need to look at the individual patient and say, you know, do we have 5 years for these deposits to dissolve? Or do we really have a good reason that we need to try to get these dissolved in 6 months or 12 months because the patient can't use their hands to do their work, or they're having such frequent episodes of attacks of gout they can't work. The serum urate can be effectively lowered by inhibition of xanthine oxidase, by inducing uric acidia, or incredibly effectively by converting urate to allantoin with replacement therapy with pegloticase. For any of these therapeutic interventions, we really do need to monitor the serum urate to know that our effective therapy is continuing and working. And urate-lowering therapy really is lifelong. Just because the attacks have stopped doesn't mean that we can back off completely on the urate-lowering therapy, because if we do, the deposits will return.
Thanks, Brian. That was great. So to close this program, gout, like many other rheumatic diseases, is now in the treat-to-target strategy. So Peter, tell us what this is all about.
Thanks so much, Len. I'd like to discuss the concept of treating to target in gout. Now, what is treating to target? It's a management strategy that's designed to maximum treatment and is especially useful in chronic disease. It considers well-defined and physiologic targets as aims in controlling disease activity, and it also considers means to achieve those aims. The two important aspects are choosing the target, and these are usually identified because they can be quantified, they can be measured effectively, and they're usually relevant to the action of the drug and to the pathology of the disease, and that they're widely and generally accepted as important targets to achieve in disease. The most important aspect of this is the treatment plan, and that has to be dynamic and responsive to changes in the patient's condition such that one can foster the development of achieving the projected target. Now, treating to target is now standard of care in a number of diseases, including hypertension, coronary artery disease, and type 1 diabetes. And it's beginning to be employed more and more in rheumatology, especially in the care of individuals with rheumatoid arthritis. Now, in rheumatoid arthritis, treating to target has been identified under many, many different names. One is tight control, another is protocolized therapy, and some refer to this as quantitative rheumatology. But there's been quite a development of strategies to use a treating to target approach to care for patients with rheumatoid arthritis. In rheumatoid arthritis, the most commonly identified target is either remission or a low disease activity state. It's generally accepted where this is possible that routine monitoring, especially every 1 to 3 months, with a standard outcome measure, and that could be the disease activity score, it could be SDI, CDI, a variety of different standardized outcome measures would be employed, and the therapy would be adjusted according to the achievement of the target. The concept here is to continue to monitor and routinely adjust therapy according to a protocol in some circumstances, as long as the target is not achieved, and that once the target is achieved, continuing to monitor closely is imperative. If a patient begins to flare, there can be an adoption of a new therapy. So this is really a way to develop a protocol around what rheumatologists standardly do to treat rheumatoid arthritis and to convince the rheumatologist that this should be done, that follow-up should be done on a routine basis. Now, it's clear that if one looks in studies of early rheumatoid arthritis, that the combination of systematic monitoring and protocolized treatment is very effective, and in fact, more effective than routine care. But there are challenges in this, and one of the biggest is physician compliance, because even when groups of physicians have agreed to the protocol and have agreed to participate in the trial, only 88% of them actually gathered the data in a routine way, and only about 2/3 of them followed the treatment schedule. There are a number of reasons for this, but treating to target is a challenge, and it's a challenge, but one with a potential reward of improved outcome. Now, in gout, we have very good treatment outcomes that we can aim toward. And as we've heard earlier from Bob and Brian, treating to a target serum urate of less than 6 milligrams per deciliter is an excellent target in gout, and that is because reaching this target gives you the opportunity to clearly reduce flares of disease activity and also to reduce tissue deposition. In individuals where tissue deposition has been extensive, lowering the urate, as Brian mentioned, to below 5 is probably of value in order to help resolve the deposit tissues. There's a very narrow window here because we know that if the urate is only lowered to the saturation level, which is about 6.8 milligrams per deciliter, flares of gout can still still occur. So we know the target in gout, at least the biochemical target. But that target may be too narrow. And again, it may be influenced by the burden of deposition of urate. It may be influenced by the stage of progression of gout, and it may be influenced by whether or not one is trying to prevent the deposition of crystals or perhaps dissolve preformed crystals. Now, there have been a number of strategies that have been developed taking into consideration the various stages of gout and how one might use understanding of these stages to create appropriate targets. So the first stage could be the initial flare. And this could occur in a person who has never had any manifestations of the disease. And there is considerable evidence that just reducing inflammation might be appropriate in this circumstance, although that remains controversial, and some would begin urate-lowering therapy at that point. Certainly when there's a recurrent flare, and you now certainly have urate crystals in the joints and in the tissue, prevention of additional flares with prevention therapy, but also lowering serum urate becomes very important. During the period between flares, lowering urate again remains an important issue to prevent subsequent flares, and also prevention therapy is very important. And then when one gets to the final stage of chronic gout, refractory to standard urate-lowering therapy, when there is chronic arthritis and recurrent flares, more aggressive therapy, perhaps with pegloticase, might be indicated, as suggested by Brian just previously. Now, when one develops a treat-to-target strategy, it's important that patients be involved in the decision about what that target is. And although rheumatologists have strong feelings about what the appropriate targets are, sometimes patients have different feelings. And here's a study from New Zealand that asked 3 groups of patients, 2 in Wellington and 1 in Auckland, about the things that they were most concerned about with management and expectations of their gout. And although rheumatologists are quite concerned about tophi, here you can see in the blue bars on the left that the patients didn't seem to be as concerned about tophi as we might have anticipated. And in fact, in the purple bars, they didn't seem to be as concerned about pain as we are. They were much more concerned about activity interference, and some were also concerned about their serum urate. So I think there's an opportunity for education here so that the target of a treat-to-target strategy in gout might be much more aligned between the physician's needs or the physician's expectations and the patient's expectations. But we believe that tophi and their resolution is a major goal, and we think this is an area in which patient education might be very important. And why do we think the resolution of tophi are important? And the first is in a very nice study by Becker and colleagues. One can see that general health, that quality of life, is highly associated with the presence of tophi. So patient-reported outcomes clearly are influenced by whether or not a patient has tophi or not. Secondly, bone damage in gout clearly is associated with the deposition of urate. Here on the upper left, you can see bone erosions typical of gout, and that occurs in locations in which there is significant urate deposition, as you can see by DEX staining in the upper right. So clearly, deposition of urate is strongly associated with the development of bone changes, and inflammation, although present, doesn't seem to be as tightly associated with bone changes as it is in rheumatoid arthritis. And finally, here's another study, again from New Zealand, showing that hand function is clearly associated with the presence of tophi in the hand. In fact, it's one of the biggest determinants of hand function, and that would be the presence of tophi. And you can see grip strength and all of these other measures of hand function are clearly associated with the presence of tophi. Can one resolve these tophi? And again, you saw some very nice information from Brian, but here's a publication from Germany showing the effect of and the speed with which uric acid deposits can be cleared after treatment, in this case with pegloticase. And on the left, you can see one patient, and the uric acid deposition in the feet is indicated by the green areas. And you can see this patient had extensive urate deposition. But after 14 infusions, you can see that those deposits were completely cleared. 14 infusions would be 28 weeks in this particular time. On the right is perhaps something even more provocative, and this is a patient who was only able to tolerate 2 infusions. Again, you can see the urate depositions in the feet, and then 4 months later, after only 2 infusions, you can see rather dramatic clearing of these urate depositions. So it may well be that one can quite rapidly clear some urate deposits with very, very intensive urate lowering therapy. So beyond tophi and decreasing serum urate, we now have preliminary criteria for remission in gout. So it might be worth considering the possibility that remission could be the real target of therapy in this disease. And these just came out in Arthritis Care and Research, but again, the areas of interest and the criteria for remission are basically a serum urate lower than 6, the absence of flares, resolution of tophi, and a marked decrease in pain and patient global assessment. How can we achieve that? We've heard discussion from Brian about the use of oral urate lowering therapy, which, as we've heard, is safe but slow. And also now in chronic refractory gout, we have the opportunity to replace the uricase, which is missing in all humans, with pegloticase, which can give rapid lowering of urate and resolution of tophi, but it also requires infusions every 2 weeks and also careful monitoring. So there is beginning to be work to define the target for gout treatment in a treat to target initiative. And again, it's serum urate less than 6. Monitoring should include serum urate and monitoring for frequency of gout attacks, and also measurement of the size of tophi. And in this strategy, it's clear that tophi can be dissolved with medical therapy, and one can do this first-line therapy with standard urate lowering therapy, second-line therapy with uricosurics, or also other urate lowering therapy, other xanthine oxidase products. And finally, in those who progress to chronic refractory gout, pegloticase might be indicated when standard therapy has not led to a persistent reduction in uric acid below a level of 6 milligrams per deciliter. So in summary, treat to target is a treatment strategy with definable, agreed upon endpoints and ways to measure them objectively and strategies to monitor them effectively. Gout is amenable to a treat to target strategy, and the target varies with the stage of disease, but at all stages, lowering of uric acid to less than 6 milligrams per deciliter is appropriate, and in chronic gout, further lowering might be necessary and appropriate. And remission is an appropriate target and may be achievable in many patients. So, thank you for the opportunity to present this information, Lenny.
It was really terrific, and you guys really covered a lot of ground. And It makes me reflect on two things. I mean, we have this chronic disease, gout, this highly prevalent disease, and there's the disease itself and then all these comorbidities. I really want to start out by asking, where does the ownership of this disease come? I mean, I'm a rheumatologist. I don't spend all day, all night seeing gout patients. You guys are gout mavens, but there's a lot of gout in community practice, not under the care of rheumatologists, and there's a growing need for rheumatologists to step up. Where should that division be?
I think the data that's emerging is very interesting in terms of utilizing not only primary care clinicians that are MDs, but also allied health professionals. And Peter touched upon therapeutic inertia, which is, I think, the best two words that we can use to describe why so many people don't really get to first base in terms of treatment to target in gout. And there's been work published from England as well as from Kaiser Permanente system, where nurses or pharmacists lead the initial efforts to get people to target. And when they enroll patients who are motivated in these types of clinics, where the bottom line is there's better patient education, and they explain to the patient that really only uric acid lowering therapy is going to be potentially curative or remission-inducing in this disease, they get spectacular results for the percentage of patients that get to target. And we're talking about 80 to 90% of patients with conventional therapies getting to target within 6 to 12 months.
I mean, I hear you, and I'm clearly aware that where you have metrology, you'll reach these targets. But I don't think that is standard of care right now in the United States for the vast majority of people with gout. So, what should be the tripwire, Brian, for a patient to go transition from a primary care to a rheumatologist in the management of their disease?
Yeah, that's really I think remains the key challenge, because as Bob said, education will work once they're in the system. I mean, if you actually educate doctor and patient, we can get to the target. But the problem is, and I tried to go through, I think the stumbling block here is that the concept that gout is an acute intermittent disease. And we have to get really the public past that, patients past that, and really all primary care providers, including our ER docs and podiatrists who see a lot of this. We need to get past the idea that once your attack is done, the disease is done until it happens again. So I think it's really wholesale education of patients as well as primary care that this is a chronic disease. And how to do that? Newsweek ads. I don't know. We've not done great. I think maybe somebody with large tophus has to be at the Republican National Convention on TV.
I think that ought to do it. So
I can suggest who, but
all right. Well, I'm kind of struck by kind of moving on to the treat to target aspect of this. That I don't do gout for a living. But I read these papers all the time, and that it is very easy to encounter a patient population that are far from the espoused targets of 6.8 or 6.0 or below. Well, where does the fault there lie? Is this provider? Is this patient adherence? Is this shared and informed decision making? Peter, how do you synthesize this?
Well, I mean, this is a highly treatable disease in which the manifestations are largely preventable. And if not preventable, certainly treatable. But I think the treat to target strategy implies a partnership between the physician and the patients where both are working to get the goal. The goal here is a persistent urate below 6, not a sporadic urate once every 2 or 3 years below 6, and not having a prescription for allopurinol. So I think it's important for us to work with all other healthcare providers and with patients to let them know that this is a condition that is highly treatable and the manifestations are preventable. And even if not prevented, the manifestations are highly treatable. You asked earlier where the tripwire is, and in my own view, when you begin to get manifestations, important manifestations of deposition of urate, be that a tophus or be that chronic arthritis, that really should be a time when that patient needs to be evaluated by somebody who has had a lot of experience treating chronic gout, because that may require far more intensive therapy than is standard practice. So this is a perfect situation for a partnership between the patients and their healthcare providers. And I personally believe it will be demand from the patients who will say, I'm tired of having flares.
For sure.
And I want to prevent all this stuff, and I want better health care.
It's very interesting, that data you showed on patient perception, that, obviously that having acute attacks is their least favorite thing, and for obvious reasons. So one thing that wasn't discussed, and this was not comprehensive, but I would just like to kind of throw this out for the discussion part of this. So we're talking about managing chronic gout, and we really didn't have any discussion of lifestyle issues for this. So is this at the level of you already have urate deposition, or you're way past that, or is that still important in the overall management package?
I think that diet is very important in terms of general overall health, and then trying to reduce the triggers of acute gout flares. But there's been an overemphasis of diet and lifestyle modification, and patients sometimes can get the feeling that that alone is sufficient to get their serum uric acid to target. The typical diet modification, along with decreasing alcohol consumption, will lower the serum uric acid by 1 milligram per deciliter at max, or maybe 1.5 milligram per deciliter at max. That's not going to get somebody who has a serum uric acid of 8 or 9 to the target.
Yeah, but the patient thinks that they're really contributing to this, and
it's empowering for patients and good for their overall health, but it's really been overemphasized as the control strategy for gout.
Right. I totally agree, and I'd even go further, and we've learned this in other conditions. We learned this with the approach to, again, cardiovascular disease, the idea of somebody with hyperlipidemia, put them on diet for a year or 6 months or 2 years, and wait for the cholesterol to come down before starting another drug. Well, it failed miserably there, and we have no reason to think that it's going to work successfully here. So, healthy lifestyle, whatever that means to the individual, is good probably for the comorbidities that Bob talked about that travel with gout. But in terms of getting rid of these massive deposits, ain't going to happen.
So let's turn and kind of focus on the tophaceous issue. So, these are my anecdotal observations, and I'm the reasonable man here. You guys are the experts. So my experience with tophaceous gout are a couple things. First of all, I'm always astounded that I seem to, when I see a patient with tophaceous gout, that generally I'm the first rheumatologist to see this person, and obviously there's a channeling bias there. If they were probably seeing a good rheumatologist, they wouldn't have these tophi. So that should be, in my opinion, just no one will be in remission with these new criteria if you still have tophi. So that's an important group. Secondly, I have managed patients with tophaceous gout for decades. And I have had many patients over this period of time that have they look like they are fixed in stone. And they might shrink a little bit, but 10 years later, they've still got that tophi that I'm feeling. So there's new opportunities for this. So, how do we get those patients? And, what is the strategy? What do we tell people as a reasonable outcome if we're using aggressive therapies like pegloticase? We're going to get rid of these things. We're going to be into this for weeks, months. What's your shared and informed discussions?
Well, I mean, we want to know what the patient's health-related quality of life is specific to the disease, gout. And we want to look at the risk-benefit ratios and the cost-effectiveness of the therapies that we administer to patients. But typically, if somebody has tophi and chronic synovitis, and they have impaired function, and they have a miserable health-related quality of life, there's a need for an accelerated pace of tophus resolution. And Brian pointed out that once we get to a serum uric acid that's below 4, the tophi start to melt at an accelerated rate. And you can get there if you combine a really potent regimen of appropriately maximally dosed xanthine-oxidase inhibition with a good potent uricose-uric strategy in many patients. But you can't get there quickly enough in some of those folks. You can't really get the serum uric acid to 1 or 2 or less than that with such oral therapies, at least the ones we have today. And so you have to look at the all of these equations and talk to the patient and see what their preferences are. In the case of pegloticase, not everybody is able to come in every 2 weeks for an infusion, for example. And we have to look at all of these factors when we make a decision. But the patients generally are more interested in really potent long-term uric acid lowering therapies for these chronic forms of gout when their health-related quality of life is severely impaired.
Okay, so we covered a lot of territory here from epidemiology, comorbidities. We've talked about the array, the palette of drugs and a treat-to-target strategy. And I think that we've clearly outlined that patients with chronic gout need aggressive therapy, and there's a growing role for a reumatologist, I believe. So that type of education among interprofessional education is really needed. So I'm going to ask each of you to close with any kind of future predictions or where you think the field should be poised to go, or what you see as the most important unmet needs. So Peter, I'll start with you. Where do you think we're going here?
Well, I think Bob outlined the explosion of information that's occurred over the last few years, both in terms of genetics, in terms of understanding the inflammatory mechanisms. And I think we're really at the stage where we can begin to think beyond treat to target, but actually to a precision medicine strategy for gout. Because we can know the genetics of an individual and which particular pathways are fostering urate accumulation. We have tools where we can lower urate to a certain degree or dramatically, and we can gauge the involvement of the patient. Hopefully in the near future we'll be able to estimate total body burden of urate and get a kind of clinical, biochemical, genetic profile of a patient and design a therapy that would be far more effective using the tools that we currently have available.
Brian, having said that, any thoughts about the prevailing interprofessional and physician-patient conundrum, the Republican convention notwithstanding?
Notwithstanding. So I think the crosstalk here comes from the comorbidities. And I think as the data are accumulating from epidemiologic initial data to now interventional studies, it's quite clear that lowering serum urate can impact chronic kidney disease progression, possibly the onset and progression of hypertension, maybe coronary disease as well. And this is the opportunity for interrelationship between us and as rheumatologists, the cardiologists, the internist to say, there are other reasons to treat the serum urate down. And I think we've moved past the smoke into the fire here. that this serum urate really is an active contributor. So I see going downstream here in time, we're going to be intervening to lower the urate in folks with chronic kidney disease in particular to slow the progression of that. So I see that as a major change and in the whole field. And in the acute flares, although it's less of an interdependency between professions or subspecialties, I see really an increased use of the interleukin-1 antagonists to treat acute attacks in the setting of patients who have so many other comorbidities that we don't like to use NSAIDs, we don't like to use steroids, we can't use colchicine. And I think this is really, to use the term precision medicine or just understanding of the biology, that's going to change the way that we approach this disease.
Okay.
I think that Brian and Peter have really expressed the precision medicine aspect of this and the rational mechanism-based therapeutic aspects of this, and then the need. We have a tremendous opportunity to improve not just the outcomes of gout with flare reduction, tophus size reduction, improved health-related quality of life due to that disease of gout, but also tremendous opportunity to improve the important global outcomes, cardiovascular morbidity, nephroprotection of xanthine oxidase inhibition emerging, some cardioprotection of xanthine oxidase inhibition emerging, and potentially the effects of uric acid and xanthine oxidase itself, these things being teased out and offering us opportunities to intervene for improved, really global outcomes in terms of these comorbidities. And with respect to the era of precision medicine and gout, it's really being launched. I mean, it started to be launched with the use of a $175 screening test, HLA-B5801, to tell you, well, if somebody's HLA-B5801 positive, such as many Han Chinese and certain other Southeast Asian population groups, as well as African Americans having more HLA-B5801 than whites, they shouldn't be on allopurinol. And then what Brian touched on with respect to adding a uricose uric to a xanthine oxidase inhibitor, this whole mechanism, rational mechanism-based thinking approach, where we recognize that the xanthine oxidase inhibition strategy as monotherapy will actually lower the uric acid production. However, it also lowers the 24-hour uric acid excretion. We really need the kidneys to get those uric acid stores down. So this idea of adding a uricose uric to a xanthine oxidase inhibitor being a rational mechanism-based approach. And then finally the precision approaches and understanding actually that the failure to respond to reasonable doses of allopurinol is not simply due to people being non-adherent or having a massive uric acid burden, but that there's a heritable trait by this ABCG2Q141K variant for resistance to allopurinol. That's not a test that we could routinely get as yet, but we're really at the dawn of that era, and we should be seeing many more of these sorts of precision medical approaches based on genomics that will help us to better treat our gout patients going forward.
I think that's the final word here. I want to thank all of you for contributing to a great program. This is clearly a field that is evolving and a moving target. And I want to thank all of you for joining us. Please come back to our website for other programs. Keep your eyes out for our next Biologic Summit and live offerings coming up. And again, thanks for being with us.